Okay, welcome back to HIMSS 2010. Mike Savilla here from Better Health, getbetterhealth.com, and we are here with Rick Smith from Allocade. So thank you for taking the time for us today.
Thank you for having us.
Our audience are basically doctors, physicians, patients. For those of people not really familiar with Allocade, how would you describe what the company is?
Allocade is a enterprise software solution that addresses the dynamics of the day of when we take over the scheduling aspect, so dynamically moving your patients through in radiology, cardiology, and surgery. That kind of addresses the uncontrollable variability and takes control of it.
Okay, well, great. And then can you tell me a little bit about the software solutions? I think I was reading a little bit about your OnQ software. If you talk about that a little bit.
Just real quickly, we try to address a connection between. We try to give all caregivers visibility, which is something that has been a problem for several years, of when the day starts. So we have communication with the ED, we have communication with the floors, so all the caregivers are involved. And what we do is, like as an example in radiology, if you took a particular modality like CT, and you had multiple CT scanners, we would give you an electronic display of all the patients that are scheduled that day. If they're inpatients, they would fall under the unscheduled, but if they're outpatients, which is usually what is shown as scheduled. And what we do at that time is then we feed over all of the order information as it comes through the systems, through the RIS system. So we have a unilateral feed with a RIS system, and we pull all that data. And as the day changes and things happen, we set with each modality, and we build a model which is based on their priorities, their preferences, their protocols, and any constraints that they may have and how they operate in their day when they're just doing it simultaneously. And we take over, essentially, built on that model automatically. Example being, I have 3 CT scanners, and I have a 16 slice, and I have a 4 slice, and I have an 8 slice, and one of my protocols is that all stroke patients go to the 16 slice, and they go immediately following the patients that's currently on the table. And so the system knows that and shoots it over. One of the scanners goes down that day, and you have to just go up on the and click on that the scanner's down. It automatically pulls all the patients and load balances across the remaining 2 without you having to do all that shuffling.
So right on the fly there, huh?
Right on the fly. It's based on artificial intelligence that was developed with the Hubble telescope. And the Hubble telescope was 10 times oversubscribed before it went into space, and they were trying to scramble how to figure out how do we do this. And the scientists, after several tries by the commercial community, could not get it done. The scientists at NASA sat down and put together an algorithm that gave them the ability to maximize every single movement of this telescope to be able to achieve the full schedule.
Wow.
It was then our founder then left NASA, and in doing so, it was a time when the government was selling off a lot of the technology they developed. He bought the rights to it and white-roomed it with new IP and took it into the fab manufacturing arena and for computer chips, and within 18 months sold that company. So it's been proven in 2 different areas as to being quite successful and actually handling more complex environments than what healthcare is. So we just eventually ended up applying it to healthcare.
Oh, wow, makes sense. So, so how does this integrate with the hospital system, or how does it interface with the hospital system?
We're kind of what I would call standalone bolt-on. We just take a feed from whatever order system, whether it's from the HIMSS or the RIS, and depending on what area, whether it be from surgery, wherever the order information is coming across. We listen for ADT messages, and we pull all order information. And usually then at midnight the day of, at 12:01, that information then is displayed on everybody has an electronic whiteboard. CT has their own, in each of the modalities. Then the floor may have a client that they work from. The beauty of it is you only see the patients that you have. So I don't see everything that's going on in radiology. As an example, I only see what's going on in my particular CT operator room for my particular scanner. I could have tabs at the bottom that would show me the other 2 or 3 CTs if they're multiple and what's happening within their environment. And then at ED, I only see my patients out of ED. But I know the status of what's going on. I know I can communicate through, we show the patient's name, we have drop-down menus that address all calls to action like start contrast drink, finish, so they can communicate back and forth without the telephone, which we know is the biggest issue when you start looking at trying to communicate in the hospital and always trying to chase everybody down. And we've looked at it, and every patient that goes through radiology, as an example, usually has to have probably 6 to 8 phone calls per patient that you have to do. And we essentially eliminate those phone calls. We have instant messaging that you can tag, and they can send back and forth between the floors or the ED of this thing may be going on, patient may be a little uneasy, may be squeamish, whatever it may be that you'd want to communicate. But again, then we also have checklists that are dropped down. And we have the nice thing about this is we have the ability to capture virtually every click that's made on the client. We can capture and timestamp. So you're getting data streams that you've never had access to before, which is a real asset to a lot of the hospitals in evaluating your workflows.
Wow. So what about hospitals that have like multiple sites within a hospital or at different buildings or different campuses? How does that work?
If they're all on the same order system, they all have visibility, and you can load balance between like outpatients. You have an outpatient facility, but you also do outpatients in the hospital, and it's close by. You could actually load balance between the two. You have an opening there, you don't here, you're overloaded. You can send them over. That everybody has communication and visibility.
Oh, great.
On the same system.
And I presume you have some hospitals that you're working with right now or have been working with?
We're very fortunate. We have 30 total customers with about 23 of those installed at this time throughout the country. We have several university teaching hospitals, University of Rochester, the University of Utah. We haven't installed yet at Medical College of Wisconsin. These are as examples, dedicated children's hospitals where there are a lot of complications because of the addition of having to have an anesthesiologist involved. It drags things out. It time crunches that you have to look at with children. We have Boston Children's Hospital. We have Lucille Packard, National Children's in D.C. We also have several large IDNs, Sutter, Kaiser, HCA, Intermountain Healthcare, VAs, a couple of VA hospitals. So we've tried to touch a lot of most of the hospitals that have those pain points that have to deal with chaos on a regular basis.
Yeah, I think hospitals kind of have been dealing with that for a long time. What about like freestanding centers? I know there's a lot of freestanding imaging type centers, that type of thing.
No, we're basically hospital focused simply because outpatient facilities can pretty well handle. They don't have a lot of chaos. It's more of a straight experience. Patient shows up or they don't show up. Within the hospital, when you're having to juggle schedules and throw things around and having to deal with inpatient stat cases, ED cases, outpatients that are already scheduled, and then trying to figure out how to maximize that is really the real issue. And the things that we really do is we give you additional capacity without question. What you do with that capacity, of course, is up to you. If you have the ability through backlogs of outpatients that are waiting for exams, we will reduce that because if you can fill the capacity, you'll get greater revenues. If you can't, what we do, you're going to find out that you don't need shift hours as long. You may start looking at reductions in cost parts because again, the capacity we know we can do. We will increase your productivity without question.